Bismillahirrahmanirrahim. This is the part 2 of the PID, Pelvic Inflammatory Disease lectures. We ended up on the clinical features, and now we started with the sign. The temperature is elevated to beyond 38.3 degrees centigrade. Abdominal palpation reveals tenderness on both the quadrants of the lower abdomen. The liver may be enlarged and tender. The vaginal examination reveals the abnormal vaginal discharge, which may be purulent, congested external urethral meatus or opening of the Bartholin's ducts through which the pus may be seen escaping out on the pressure. Speculum examination shows congested cervix with purulent discharge from the canal, and bimanual examination reveals the bilateral tenderness on fornix palpation, which increases more with the movement of the cervix, and there can be thickening or a definite mass felt through the fornices. So this later part is very important. One is the speculum, that we have to do the speculum. We insert the cusco-speculum and then we see the cervix under the lamplight, and then the bimanual examination, that is, we have to insert one hand inside the vagina and the other hand on the abdomen, and then we will feel with our two hands the tenderness on the fornix palpation. Again, we will move our hands on the right and left fornices, and this again, if there is pain, the patient feel pain on the movement of the cervix, and also you have to feel the mass. There can be thickening or the definite mass which are felt through the fornices. So we can feel the tenderness, we can feel the mass, and also we can assess that whether this tenderness is due to the movement of the cervix or not. Then again, clinical features. Quickly, clinical features of the acute PID, that is fever, 38 degree, bilateral abdominal tenderness with the radiation to the legs, abnormal vaginal discharge, uterine bleeding, dyspareunia, cervical motion, adnexal tenderness on bimanual examination. Clinical diagnostic criteria of the PID, that is minimum criteria and additional criteria, and again definitive criteria. Minimum criteria, that is adnexal tenderness, cervical motion tenderness, uterine tenderness, that there is tenderness, the patient feels pain when you touch. Additional criteria, oral temperature, that is more than 101 degree, more than 38.3 degrees centigrade, abnormal cervical mucopurulent discharge or cervical friability. Again, discharge is the very good, it is the sign that you see. Presence of abundant numbers of the WBC on the saline microscopy of the vaginal fluid, elevated ESR, elevated C-reactive protein, laboratory documentation of the cervical infection with Neisseria gonorrhea or Chlamydia trachomatis. Definitive criteria, endometrial biopsy with histopathologic evidence of the endometritis, transvaginal sonography or the magnetic resonance imaging techniques showing the thickened fluid-filled tubes with or without a free fluid, pelvic fluid or tubo-ovarian complexes, or Doppler studies suggesting the pelvic infection, for example, tubal hyperemia, inflammation. Laparoscopic findings consistent with PID. So, the laparoscopic findings, Doppler studies, transvaginal ultrasound, and biopsy, they are all the definitive criteria. Classification again, subclinical, silent 60%, mild to moderate symptom 36%, over to that is 40%. Again, it's going towards the mild, moderate to the severe symptom, that is left only 4%. Because these symptoms, they are usually make the patient to go to the doctor when the disease is at the mild level, or sometimes subclinically, and silent it is accidentally discovered and the patient is coming for some other purpose. But again, if there is mild to moderate symptoms, the patient, they are enough to make the patient to go to doctor to seek the help. Investigations. A pregnancy test should always be performed to exclude the important definitive diagnosis of ectopic pregnancy. High vaginal and endocervical swabs, high vaginal for Trichomonas vaginalis, Candida, and bacterial vaginosis, endocervical for gonorrhea, and endocervical for chlamydia. Please do not forget these two names, gonorrhea and chlamydia. Gonorrhea and chlamydia, sexually transmitted infections, these are very important. Should be taken paying attention to using the correct technique. Midstream specimen of the urine should be sent for microscopy and culture. Full blood count and C-reactive protein, they are important if the woman is systemically unwell. If she is not well, then you can send the full blood count and C-reactive protein. And urea electrolytes should be analyzed if she is vomiting. So vomiting again is a very important symptom. Serological test for syphilis should be carried out for both the partners in all the cases. Investigations. Ultrasound scan will exclude a large tubo-ovarian collection but is usually normal with PID except for possible free peritoneal fluid, which is a non-specific finding. Coldocentesis, aspiration of the peritoneal fluid and its white cell count. If exceeds 30,000 per ml is significant in acute PID. Bacterial culture from the fluid is not informative because of vaginal contamination. Investigation, they are also to be extended to male partner and smear, and culture they are made from urethral secretions. Laparoscopy, it is indicated if the diagnosis is unclear or there is no response to treatment after 48 hours. So 48 hours are very important. So ultrasound and coldocentesis, this is when we draw the fluid, peritoneal fluid, and we will see the infection, whether there is inflammation is there, we do the culture, and then the culture of the partner is very important. Laparoscopy, as I told you before, this is standard, it's considered the gold standard. While it is the most reliable aid to support the clinical diagnosis, but it may not be feasible to do in all cases. It is reserved only in those cases in which differential diagnosis includes salpingitis, appendicitis, or ectopic pregnancy. Laparoscopy helps to aspirate the fluid or pus for microbiological study from the fallopian tube, ovary, or pouch of Douglas. Non-responding pelvic mass needs laparoscopic clarification. So in this picture, you can see this is the laparoscope, it is inserted, a pneumoperitoneum is created, and we can see the uterus, fallopian tube, and of course we can see the other viscera if there are adherents, and fallopian tubes directly we can see whether they are inflamed or congested or not, and what is the extent of disease. If there is ectopic pregnancy, you can again rule out salpingitis, appendicitis, they are all, we have to differentially diagnose all these from one another. Laparoscopy. Laparoscopic findings and severity of PID: mild tubes, edema, erythema, no purulent exudates, and mobile. If it is moderate, then purulent exudates from the femoral ends, tubes not freely movable, severe, pyosilpings, inflammatory complex abscess, violent sting like adherence in the pelvis and around the liver suggests the chlamydial infections. So there is adherence which are due to the chlamydial infection. You can see this violent sting adherence of the chronic Fitz hug Curtis. These are the adherents. You can see this is a view from the laparoscopic view, and you can see that how these adherents they are prominent looking. Differential diagnosis. The clinical condition may be confused with appendicitis, disturbed ectopic pregnancy, torsion of the ovarian pedicle, hemorrhage or the rupture of the ovarian cyst, endometriosis, diverticulitis, urinary tract infection. Please do not forget this. In female, very important. The two conditions, acute appendicitis and disturbed ectopic pregnancy, must be ruled out because both the conditions require urgent laparotomy, and whereas acute salpingitis is to be treated conservatively. Clinical features of the acute salpingitis, appendicitis, and disturbed ectopic. You can see these symptoms, and you can just compare with the acute salpingitis, appendicitis, and disturbed ectopic. You can see this pain, amenorrhea. In this case, pain when there is acute lower abdomen on both sides. In case of salpingitis, in case of appendicitis, it is in the right iliac fossa. If there is ectopic pregnancy, this is lower abdomen on one side, which is the side where there is ectopic pregnancy. Amenorrhea and bleeding PV, that is unrelated, and again unrelated, but usually it is present. And GI symptoms such as nausea, vomiting, inconsistently present. Usually it is there in appendicitis, and no, it's not, it's absent in the ectopic pregnancy. General look, face flushed in the case of salpingitis, toxic in the case of appendicitis, and pale in the case of disturbed ectopic. Tongue, no significant change. It's a furred and pale in the case of ectopic. Pulse, rapid but proportionate with the temperature. Yes, if it is tachycardia, of course, there is hyperparaxia. Rapid out of proportion to temperature. So pulse is very rapid. Persistent rise even with normal temperature. So in acute abdomen due to the ectopic pregnancy, this is rapid feeble pulse. Temperature more raised, slightly raised, not raised in ectopic. Tenderness, lower abdomen on both sides. On McBurney's point may have muscle guard. You know this McBurney's point, and it is the junction of the, it is the line which you draw from the anterior superior iliac spine to the umbilicus, and it is midway between at the junction of 1/3 and lateral 2/3. This is point shows the muscle guard. Lower abdomen more on one side, in this case of ectopic. The last but not least, that is pervaginum. Tenderness on both fornices, MS may be felt. Tenderness on the right fornix and high up. Mass may be felt through one fornix extending up to the pouch of Douglas. So how we can differentiate between these three important conditions? Complication of the PID immediate, that is the number one is the pelvic peritonitis or even generalized peritonitis. Number two, septicemia producing arthritis or myocarditis. So joint pains, do not ignore these joint pains when the patient comes to you with these symptoms of joint pains, and also myocarditis. Late dyspareunia, that is painful coitus, and infertility rate is 12% after 2 episodes, increases to 25%, and even 3 raises to 50%. It is due to tubal damage or tubo-ovarian mass. Chronic pelvic inflammation, it is due to the recurrent or associated pyogenic infections. Then is the formation of adhesions or hydrosalpinx or pyosalpinx and tubo-ovarian abscesses. Number 5, chronic pelvic pain and ill health. And number 6 is increased risk of ectopic pregnancy, 6 to 10 times increase. Treatment. Principle of the therapy, they are number 1, to control the infection energetically, that we have to immediately take action. And number 2, the prevent infertility and the late sequelae. And number 3 is to prevent the reinfection. Treatment, outdoor therapy. Apart from the adequate rest and analgesia, antibiotics, they are to be prescribed even before the microbiological report is available. Because the infection is polymicrobial in nature, instead of single, combination of antibiotics should be prescribed. Outpatient antibiotic therapy for acute PID is given in the next table. So treatment, again, you can see that ambulatory management of the acute PID, patient should have oral therapy for 14 days. In regime 1, you can give levofloxacin 500 mg, that is once a day, and metronidazole 500 mg BD. In regime B, ceftriaxone, doxycycline, metronidazole, you can give. Broad spectrum antibiotic coverage, that is cefotaxime, cefoxitin, it is indicated as most PID, they are polymicrobial, that is gram-negative and positive aerobes as well as anaerobe rods and cocci. All patients treated in the outpatient, they are evaluated after 48 hours, and if no response, are to be hospitalized. Treatment, inpatient therapy. The patients are to be hospitalized for antibiotic therapy in these conditions. Indications for hospitalization, that is number 1 is suspected tubo-ovarian abscess, severe illness, vomiting, temperature more than 38 degrees centigrade, uncertain diagnosis where surgical emergencies, that is for example appendicitis, cannot be excluded. Unresponsive to outpatient therapy for 48 hours, intolerance to oral antibiotics, which is very common in our culture, and then coexisting pregnancy, patient is known to have HIV infection. And then again, We continue with the bed rest, oral feeding is restricted, dehydration, and acidosis to be corrected by intravenous fluid. Intravenous antibiotic therapy recommended for at least 48 hours but can be extended to 4 days if necessary. Improvement of the patient is evidenced by remission of the temperature, improvement of the pelvic tenderness, normal white blood cell count, and negative report on the bacteriological study. So when there is no pyrexia and patient is fine, general health is fine, it is indication. And again, in the table, inpatient antibiotic therapy, we have regime 1, regime B, and alternative regimes. In regime 1, that is cefaxetine. Again, it is 2 gram IV 6 hourly for 2 to 4 days plus doxycycline 100 milligram, that is per oral for 14 days. Regime B, clindamycin 900 milligram IV every 8 hours plus gentamicin 2 milligram per kg IV loading dose followed by 1.5 milligram per kg IV maintenance dose every 8 hours. Alternative regime, levofloxacin, that is 500 milligram IV once daily with or without metronidazole 500 milligram IV every 8 hours. Regime B, it is referred for cases with pelvic abscess and it has anaerobic coverage. Alternative regime is dosed, it is once a daily. Treatment indication of the surgery are comparatively less. Unequivocal indications, they are generalized peritonitis, pelvic abscess, tubo-ovarian abscesses which does not respond 48 to 72 hours to antimicrobial therapy. Prevention, the following formalities are to be rigid following to prevent reinfection. Educating the patient to avoid the reinfection and the potential hazards of it. The patient should be warned against multiple sexual partners, to use condom. The sexual partners or partners, they are to be traced and properly investigated to find out the organisms and treated effectively. If they have got non-gonococcal urethritis, they should be treated with tetracycline 500 milligram 6 hourly or doxycycline 100 milligram twice daily for 7 days. Pregnancy, PID is extremely uncommon in pregnancy, probably due to the mucous cervical plug and pregnancy itself impeding passage of the organism into the fallopian tube. In pregnancy or breastfeeding, penicillin or ceftriaxone can be used instead of ciprofloxacin. Erythromycin should be used instead of doxycycline or azithromycin, although azithromycin is not known to be harmful. Follow. Repeat smears and cultures from the discharge are to be done after 7 days following the full course of treatment. The tests are to be repeated following each menstrual period until it becomes negative for 3 consecutive reports when the patient is declared cured. Until she is cured and her sexual partner have been treated and cured, the patient must be prohibited from intercourse. The only unequivocal proof of successful treatment after salpingitis is an intrauterine pregnancy. Thank you very much. Jazakallah khair.